Welcome, everybody. We appreciate your attendance at today's PC-PCC webinar entitled In Search of Joy in Practice, Innovations from 23 High-Functioning Primary Care Practices. My name is Ted Epperly. I'm a family physician in Boise, Idaho, and the co-chair of the Center of Care Delivery and Integration. This webinar is sponsored by the PC-PCC's Care Delivery and Integration Center. And I just want to give just a couple background notes. If you haven't seen it yet, access PC-PCC's new publication that presents a crosswalk of 5 major public policy proposals and their support for patient-centered primary care as the driver of health system transformation, entitled The Primary Care Consensus, a comparison of health system transformation proposals, and you can access that on pcpcc.net. Again, that's on pcpcc.net. I also wanted to take the opportunity to highlight next month is Behavioral Health Month for the PC-PCC, and we'll be focusing our communication efforts on behavioral health. The next webinar will be July 11th at noon Eastern Time. It's free to the public, and that will be Behavioral Health Integration in the Medical Home, an overview of the Massachusetts Self-Assessment Online Toolkit. Registration deadlines will also be on the pcpcc.net. The next national briefing will be July 30th at 11 a.m. Eastern Time, again, free to the public, and that will be entitled The Colorado Experiment, Primary Care and Behavioral Health. Registration details, again, accessible on pcpcc.net. The upcoming Fall PC-PCC Conference will be October 13th through the 15th in Bethesda, Maryland. That'll be a new venue in Bethesda. Registration details also accessible on pcpcc.net. I want to remind you that if you want to have questions for our 2 great presenters today, please write them down in your Dropbox, in your question box that you have, and I will read those to our presenters at the conclusion of their lecture. So again, put questions in the question box. I want to now give you some brief background on both Christine and Thomas Sinsky. Chris and Tom are general internists at the Medical Associates Clinic and Health Plans in Dubuque, Iowa. They are frequent invited lecturers on practice innovation, redesign, and patient-centered medical home, and have given workshops for the American College of Physicians, the Institute for Healthcare Improvement, the New York City Department of Public Health, as well as private and academic medical centers. Dr. Christine Sinsky serves on an expert advisory panel for the CMS Innovation Center's Comprehensive Primary Care Initiative. Both Dr. Sinskys are investigators for an ABIM Foundation study of high-functioning primary care practices, which is published in the Annals of Family Medicine article and is the topic of our webinar today. And now, without further ado, I'd like to turn it over to Chris and Tom Sinsky.
Thanks so much, Ted. It's really a pleasure to be with all of you today to talk with you about joy in practice and the innovations that we found in visiting 23 high-performing practices. Our agenda for the next little hour or a little bit less will be to talk first about some framing thoughts around burnout, and then spend most of our time talking about the ABIM Foundation-sponsored study In Search of Joy in Practice. And we've left plenty of time for discussion, so we really look forward to making this interactive at the end. But what I'd like to do to start is to introduce you to 3 good men. The first is a medical school classmate of mine, and he has been a family physician in rural Wisconsin for 25 years. And he was honored by his colleagues as the Wisconsin Family Physician of the Year a few years ago. But he has recently left his practice. He's taken on a new specialty. And he told me what he wanted others to know about why he did this was that he felt crushed by the demands, some or many of them unnecessary. And he felt heartbroken at the loss of his dream of family medicine. Another physician is a high school classmate of my husband's. He too was honored by his colleagues. He was the past president of the New Mexico Academy of Family Physicians. And he told us recently, I just don't know how long I can keep going with this. I don't know if I can keep doing it much longer. And then finally, this is Dr. Ben Crocker, and he is a general internist at the Mass General Hospital in Boston. And I had shadowed him in his practice in 2008. And he subsequently sent me an email in which he said, "There's not much real time to listen to patients. The little things have become the big things. I fear our roles as healers, comforters, and listeners are being lost. Working at Starbucks seems like it would be better." So I'd like to start by thinking about burnout. And this is a study from the Archives of Internal Medicine from last fall, where the authors identified that nearly 50% of physicians in the United States are burned out, and that those in general internal medicine and family medicine are at greatest risk for burnout. You might wonder, well, why does burnout matter? But when we're burned out, our care isn't as good. We make more mistakes. Our patients adhere less to our treatment recommendations. We show less empathy to our patients, and our patients are less satisfied overall with the care that we provide. So the authors of the archive study concluded that if 1 out of every 2 physicians is exhibiting some sign of burnout, then the problem has to be rooted in the environment and in the care delivery system itself, rather than reflecting some personal weaknesses on the part of a few susceptible individuals. So medical students are noticing this, and they are avoiding primary care. And the number of medical students choosing primary care has plummeted over the last 20 years. And even though in the last couple of years it's come up, the overall trend has been that the pipeline of primary care physicians is diminishing. And in 2010, only 9% of medical students had selected either general internal medicine or family medicine as their residency choice. Well, not only are the trainees avoiding primary care, but the elders of the tribe are leaving, and we're leaving at a faster rate than our subspecialty colleagues. In fact, we're leaving, general internists are leaving at about 5 times the rate of our subspecialty colleagues. And the reasons for this are generally cited as chaotic work environments, little control over our work environments, and overall burnout. So I'd like to turn our attention now to the study In Search of Joy in Practice, and to first highlight the co-investigators, and again thank the ABIM Foundation for its sponsorship. And then point you toward the study that was published in the May Annals of Family Medicine issue, and to let you know that that's open access, so anyone can reach that. I also wanted to identify our advisory council. We were really fortunate to have top leaders from almost all of the primary care organizations that touch, all the organizations that touch primary care. The American Academy of Family Physicians, the American College of Physicians, PCPCP, the Veterans Administration, the American Academy of Nursing, and a variety of other organizations help to guide this work. And the central question that we asked was, in light of this dismal situation in which primary care finds itself, with fewer residents choosing primary care, practicing physicians leaving at a fast rate, are there places where primary care physicians and their staff are thriving? Places where the work of primary care is both doable and enjoyable as a life vocation. And so we were able to identify 23 high-performing sites, sites where we felt that patients were getting good care, and sites where we felt it was enjoyable for the physicians and their staff to be working. Now, it turned out that the majority of our study sites were patient-centered medical homes, although that wasn't an entrance criteria. And one or another of the investigators, we spent a day shadowing the physicians, the nurses, the medical assistants at the practice as they were doing their work, and we also talked with leaders in the practice. And our lens was focused at the most granular level of workflow and task distribution. Who does what in the practice? We also looked at how does the physical space and the technology infrastructures either help or hinder the teams as they're doing their work. And from those observations, we put together 5 challenges that we felt were very common in primary care practices. The first, chaotic visits with overfull agendas. Second, inadequate support to meet the patient demand for care. Third, vast amount of time spent documenting the care and complying with administrative and regulatory requirements. Fourth was EHR implementations that pushed more work to the physician. Work that previously may have been done by a receptionist, a medical records clerk, a pharmacist, a transcriptionist, has now in many instances become the daily work of the physician. And teams that function poorly and complicate rather than simplify the work. So for each of these challenges, we've identified innovations that we found that can help to address those challenges. And then we've also identified some action steps that different actors within the healthcare system can take to help strengthen and spread these innovations. So the first, chaotic visits with overfull agendas. The innovations here are all around planning ahead with pre-visit planning, pre-appointment lab, and then taking a systematic approach to prescription management. So the first clinic I'd like to describe for you is Fairview Clinic in Minneapolis. This is a large integrated delivery system, and they have embarked on a system-wide initiative which they call Care Model Redesign. Now one element of this is the MA pre-visit phone call. So a day before the patient's appointment, the MA will call all the people on the next day's schedule. And during that call, she will identify the patient's agenda so that they are able to be prepared and they're not caught off guard by a new agenda item that the patient may have had. She does medication review, which she can do with the patient at home where they can actually look at their bottles and they can work to get a very reliable list of what the patient's actually been taking. They do some standardized condition screens. So, for example, she'll do a depression screen during that call. And then, as appropriate, she'll have a conversation about advanced directives. And then she takes all that information that she's gathered, and she'll pre-populate the next day's visit note, again to make the clinic day, the next day go more smoothly. At Mayo Clinic Red Cedar, one of the satellite clinics of the Mayo Clinic, the nurse calls the patient a week before their appointment and arranges for them to come in for pre-visit lab. And she orders that lab based on protocols that they have based on the medications and the conditions that the patient has. And the reason they do this is they realize that when the patient and the physician and the lab are all together, when the patient and the physician can discuss the lab results at the appointment, the care is better. The patient can be engaged in shared decision-making that way. And in addition, it eliminates a lot of post-appointment results reporting. We found that for most practices, for every 4 hours of clinic session, there's another 2 hours of post-appointment results reporting work. And if you do the lab ahead of time, as Mayo Clinic has found at Red Cedar, they can eliminate most of that post-appointment results reporting. At Theta Care, the patient arrives through their appointment, the blood is drawn, and they have designed systems so that within 15 minutes, the results are back to the room. Again, with the same of making sure the patient and the physician can discuss the lab results face-to-face at the time of the visit for better patient care, and then also to reduce the amount of unnecessary chasing after patients to give them the results and respond to those results. Now, several of our study sites have taken a systematic approach to prescription renewals. And so in those practices, all of the chronic illness prescriptions are renewed for 12 or even 15 months at the time of the annual comprehensive care visit. Now, that's not the only time the patient is monitored, but it's the only time stable prescriptions need to be renewed. That eliminates the need to keep redoing the same work over and over again throughout the year. Now, we estimate that this saves about 30 minutes of physician time per day and about an hour of nursing time per physician per day. We've noticed that it's not uncommon for a group of 6 to 8 physicians to hire one nurse who does nothing but prescription renewal work throughout the day. And that's a lot of nursing resources that can be redeployed elsewhere. And if we look at the sum of all of this time, you might say, well, big deal, 30 minutes of physician time or an hour of nursing time. But if we convert that into capacity in primary care, and we convert that into one more appointment per day across all primary care physicians in the country, that converts to access for 80 million more primary care visits per year, which to me shows the potential waste that, that's going on right now around prescription renewal work. So the action steps here that we've identified include at the insurer level, developing policies for only a single copay for the patient if they have their lab the same day as their visit, or if they have their lab visit. At the institutional level, to develop the capacity to hold future orders so that a clinic can set up an appointment, return in 6 months with this lab ahead, and the institution can hold that lab. And at the regulatory level, at the state-by-state level, to ensure that there is the authority to provide a 15-month window for prescriptions. So the second challenge is inadequate support to meet the patient demand for care. And the innovations here are all around sharing the care among the team. And we found that the most robust models had 2 or even 3 nurses or medical assistants per provider. This allowed a much more robust rooming protocol, and it also allowed the staff to be involved in a lot of between-visit care with health coaching, care coordination, and panel management. Here's Mayo Red Cedar again, and this is Dr. David Eitram and his 2 nurses. And they have designed what they call the new model of nursing. And they went from a 1-to-1 ratio to a 2-to-1 ratio. And with this, they were able to move from a physician-centric model of task distribution and responsibility to a team-based model. And these nurses have taken complete ownership of immunizations in the practice. They do all of the organization around cancer screening. They do the diabetic foot exams. They do lifestyle counseling with every visit. They have some nurse-only hypertension visits. And when I was there and I asked them, well, what's different in your new model? They said that even though they feel less harried, even though they are able to see 25% more patients, they're able to provide access to 25% more patients. They feel less harried at the end of the day. And they're also justifiably proud of the fact that they can now proactively reach out to a patient who has diabetes, who may have been falling off track, and they can bring that patient in, help them get their risk factors under control, and help them avoid the devastating complications of diabetes, all in a way that they hadn't been able to do previously. So the action steps here at the educational level, I think we can encourage educators to be sure that included in nursing and medical assistant training are skills in motivational interviewing and self-management support. At the institution and regulatory level, we encourage institutions to be bold, to recognize that higher levels of staffing have better outcomes, both better financial outcomes and better satisfaction outcomes, and I suspect also better quality outcomes. And then to look at scope of practice, to in many cases expand the scope of practice for the medical assistants and at times the nurses as well. So I'm going to turn it over to Tom to tell us about the third challenge.
The third challenge that we discovered to join practice was the vast amounts of time spent documenting care. I think those of us in primary care often feel like we're spending more time documenting the care than actually delivering the care. This is something we heard from a primary care internist in Alaska. She said, "I used to be a doctor. Now I'm a typist." This is a picture from 1891 entitled "The Doctor." And I'd like you to just take a minute and look at the picture and think about what you see here. Well, what we see when we look at this picture is the undivided attention that the physician provides for the patient. Well, that's a portrait of the physician in 1891. This is a portrait of the physician in 2013. Again, I'd like you to just take a minute and think about what you see in this picture. Well, what we see here is what's frequently been described as continuous partial attention. Now, to deal with this challenge, we discovered innovations that included scribing, that is visit documentation by other members of the team, and also assistant order entry. This is Dr. Peter Anderson of Newport News Family Practice in Virginia. When I visited Dr. Anderson's practice, he told me that about 10 years ago, he was on the edge of burnout. He was about to leave his practice. He was seeing fewer and fewer patients, spending longer and longer days at the office. He told me, "I felt like I was becoming a ghost to my family." He had to do something different. He went on to develop what he calls the family team care model. When I visited Dr. Anderson's practice and I saw the family team care model in operation, I saw and I experienced what I think we'd all hoped for when we were residents and medical students and hoping to become primary care physicians. Dr. Anderson spends his days listening to his patients, talking with his patients, making medical decisions, and really making an impact for each person that he sees. And he's able to do this because he has a team of 3 nurses working with him. Dr. Anderson told me that the real breakthrough for him came when he realized that there are really 4 components to an outpatient primary care visit. First, there's data gathering, then organizing and documenting the data. Then there's analysis of the data and the physical exam. Then medical decision-making and creating a plan for the patient. And finally, implementation of the plan, order entry, and patient education. Dr. Anderson realized that really only the second and third components of the visit required the physician, and the first and fourth components could be managed by other members of the team. I'd like to take a minute and just describe what a patient visit to Dr. Anderson's practice looks like. When the patient first arrives, they spend the first 8 to 12 minutes with the nurse. During this time, the nurse gathers, organizes, and records the important data for the visit. This includes vital signs, medication reconciliation. She brings forward and prints the previous 2 visit notes to place this visit in context. She brings forth any recent emergency room notes or consult notes that are pertinent. Also prints up any new lab or x-ray results. She then spends time with the patient, ensuring that the patient and the physician are on the same page as far as the agenda for the visit. She takes a history of present illness and documents that in the electronic health record. And then, guided by templates, she obtains an appropriate review of systems. So all this information is gathered, organized, and recorded before the physician enters the room. Dr. Anderson then enters the room and joins the nurse and the patient. At this time, the nurse gives report. This is quite similar to the way a resident physician will give report to an attending physician on hospital rounds. She orally describes all the information that she has gathered. And during this time, Dr. Anderson listens carefully. He asks further questions of the nurse and of the patient to further probe the history and the details of the patient's presentation. He then goes on to perform the appropriate physical exam, and then he makes his medical decisions. He verbalizes any medication changes, any lab and x-ray orders, diagnosis and billing codes, and the next follow-up appointment when he wants to see the patient again. All that is documented by the nurse. Dr. Anderson then leaves the room and moves on to the next patient who's been prepared in a similar way by one of his other nurses. In the meantime, this nurse stays with the patient. She reviews the plan. She prints up and reviews the visit summary, and then escorts the patient to the checkout. Dr. Anderson has been shadowed by over 50 physicians who wish to learn about his plan of care. And recently, just over the past 1.5 years, he's left his practice, and he's now instructing large organizations in his family team care model. For instance, one of the large organizations most recently was the United States Army Outpatient Clinics. This is Dr. Kevin Hopkins. Dr. Hopkins is a young family physician at the Cleveland Clinic. When I visited Dr. Hopkins, he told me that just 2 years out of residency, he was feeling burnt out. He was feeling he had to do something different or he was going to quit. Luckily, he heard about Dr. Anderson's practice. He spent time in Virginia learning some of those techniques, and he brought them back to the Cleveland Clinic. Now, when Dr. Hopkins came back to the Cleveland Clinic, he had to present a business plan in order to justify the additional staff that he would need. And he estimated that if his staff and he could see just 2 more patients per day, that would cover the cost. It turns out now that he's been in his new model for the past few years, he actually has increased his access for patients from 21 to 28 visits per day. His revenue has increased by 30%, and the Cleveland Clinic has asked him to spread this model to other members of their primary care departments. When I spoke with Dr. Hopkins and his medical assistants at the end of my visit, I said, what would you like me to tell other people when I tell them about your practice? And they said, tell them we're having fun in primary care. And when I spent my day with them, I really did see them having fun and really enjoying their work. Dr. Hopkins told me the medical assistants are more fully engaged in patient care than they ever have been, and they enjoy their work. They have increased knowledge about medical care in general and about their individual patients in particular. And the medical assistants echoed this when I spoke with them. They said, you know, we learn something new every day when we come into work because we're with that patient through the entire visit, and we really understand what's going on with those medical decisions. And also, we've developed very deep relationships with these patients because we're spending so much time with them. This is another one of our study sites, the University of Utah at Redstone. They also have a collaborative care model. Here they have 2.5 medical assistants for each physician. I think this picture really captures the model. Here you see the physician providing that undivided attention to the patient, fully focused, while the medical assistant is doing the important work of visit documentation and order entry. Another one of our sites was Dr. Amy Halpert in Cambridge, Minnesota. She works with 2 nurses in a similar model. And she told us, I now get to look at my patients and talk with them again. We're reconnecting. Our patient satisfaction numbers are up. Our quality metrics have improved. Our nurses are contributing more. And I'm going home an hour earlier to be with my family. This is Dr. Joe Kim at the Office Practice of the Future at the Quincy Family Medicine Training Program in Quincy, Illinois with the University of Illinois. In their practice, they have 2 medical assistants and 1 LPN teamed with each physician. The medical assistants, each of them work in the room with the physician documenting the care, providing order entry. And the LPN is at the desk doing all that intervisit care that needs to go on, speaking with patients on the phone, following up with with prescriptions and so forth. So of our 23 sites, 6 of them had a collaborative care model, which included scribing and team order entry. And we found similar results. Access for patients was increased by 30%. The cost of the additional staff was covered. Satisfaction, not only for the physician, but for the staff and patients, increased. Quality metrics improved. And across the board, physicians were going home from work an hour earlier, And they were not taking that additional 1 to 2 hours of documentation work home with them to do at night, which we see so often in other practices across the country. As far as action steps that can help with these innovations, again, institutions need to provide these robust staffing ratios and also have to allow assistant order entry under the direction of the physician.
Thanks, Tom. So the fourth challenge that we'd like to share with you is computerized technology that pushes more work to the clinician. Here's a physician in Des Moines. The task list is unbearable. I spend an hour and a half clearing out my task list before leaving and another hour and a half at home after the kids go to bed. So the innovations that we found here are all around messaging, verbal messaging and inbox management. This is Fairview Clinic again, and at Fairview they have empowered the medical assistants and the nurses to take work off the work list. So if there's anything in the inbox that they're capable of managing, they take care of it. If there's a question from the patient, lab results to be reported, prescriptions to be renewed that they can do by protocol, they pull that off instead of sending it to the physician. And they only send out to the physician that small number of inbox messages that really require a physician level of engagement. After doing this, what they found is that they've been able to reduce the amount of what they call the backpack work, the work the physician takes home every night, from an average of 90 minutes a day per physician to, for many of their physicians, just a few minutes a day. The other thing I wanted to point out in this picture was line of sight. You can see the medical assistant at her station, and you can see that she can see the status of each of the exam rooms for which she's responsible for from her station, which is an element of efficiency supported by the design of the clinic. In fact, at Fairview, they designed this entire clinic for the medical home and also for efficiency and built in a lot of line of sight. Now, many of our study sites began their electronic journey understandably thinking that asynchronous electronic communication was going to be the most effective and efficient way for communication. But as the years go by, have discovered that, in fact, verbal messaging, that is, talking to each other face-to-face, is oftentimes the most efficient and the most comprehensive way to communicate. And what this does is you can quickly go through a stack of messages person to person and prevent that series of email messages going round and round in an electronic thicket through the office. The innovation that I'd like to share with you here is the semicircular desk. So this is at the ambulatory practice of the future associated with the Massachusetts General Hospital. And you can see that the physician and the patient can face each other during the interview face-to-face. And then if they need to, they can turn slightly and make it a three-way conversation to include the electronic information source, rather than the physician having his shoulder or his back to the patient through much of the interview. A variation on this at Aora Health is here, and you can see this very comfortable setup between the patient and the physician. The physician is leaning forward, is giving the patient undivided attention, and the technology is there, and when they need to, they can both turn and look at the monitor on the wall. The other thing I want to highlight here is the third person in the room, the person in the foreground, and that's one of what they call their health coaches. And the health coach stays with the patient from the beginning to the end of their appointment. So the health coach does the rooming component, then remains in the room for the physician component, and at this time he's assisting with some of the documentation of the visit, and then he'll stay in the visit afterward and help to reinforce the plan, set up times to communicate with the patient between visits. So the action steps that we've identified here include, at the institutional level, to be intentional about decreasing message generation in the first place. We need to send messages not just because we can, but only when we really need to. So we don't need to notify the physician of every mammogram that's been ordered or of every missed appointment. Those messages can be handled in another way. And secondly, to empower the nurses to filter the inbox. Now the fifth challenge is teams that function poorly and complicate rather than simplify the work. And the innovations here are all around creating forums for communication through co-location, daily huddles, weekly team meetings, and then using workflow mapping as a technique to improve processes. So this is what's called a flow station at North Shore Physicians Group in the Boston area. And you can see the physician and the medical assistant are seated side by side. So they do a lot of communication right there. They accomplish many of their messages this way. Education occurs here, and it's a very efficient setup for them. Now, when I spoke with the leaders at North Shore Physicians Group, they told me of a senior physician in their practice who had a large panel. He had 2,500 patients in his panel. They were older and more complicated. And he used to take home 2 hours of work every night. But within a couple of months of being set up in this physical arrangement, he was going home without taking any work home. And now many of the other physicians are asking to have this kind of co-location. Another variation and extension on the idea of co-location includes co-location of the scheduler. So having the clerical staff co-located with the clinical staff. And this is a scheduler at Fairview, and when I was there, she was really excited, and she said, you know, I really like the fact that I can take work off the plates of the medical assistant and off the nurse, and because she's located right there, she gets to know their work, she knows how she can be helpful. In addition, she's in close contact with the physician, so the physician can quickly instruct her on what to arrange for the patient. This is South Central Foundation in Alaska, a truly amazing organization, recently honored by winning the prestigious Baldrige Award. Now, the care model at South Central Foundation is based on one provider, either a nurse practitioner, a physician's assistant, or a physician. So a provider, a nurse, a medical assistant, and a clerk. And that integrated care team of 4 people makes up the tight team. Now, in this communal space, they'll be housed 3 integrated care teams. And then those teams are surrounded by an extended care team that includes a pharmacist, a social worker, and a nutritionist. So if the physician has a question about a medication, there's a pharmacist right there that he can ask on the spot. If the nurse feels that the patient may need behavioral health or social work resources, she can bring the social worker into the room, and they can make a warm handoff right there, again, on the spot. Here's a similar setup, a similar bullpen arrangement at the ambulatory practice of the future. And you can see the space for co-location of different categories of healthcare workers. You can also see line of sight. Line the perimeter of this space so that people at their stations can see the status of those exam rooms. This is the University of Utah holding one of their regular team meetings. And the idea here is that we all come to work every day, not only to do today's work, but to work together to make tomorrow's work better. This is Iora Health. And when I visited this group, the day I visited, one of the health coaches was running the meeting. Their health coach is like a medical assistant. And what they told me was, we all own the outcomes of the practice, and we all own the meeting. And by having distributed leadership, or different members of the team took leadership positions, they could make that manifest. This is Theta Care. Theta Care in central Wisconsin is another amazing organization. All of the staff are trained in the language and in the methodology of quality improvement. And they have adopted Lean as their change management strategy. And when you go there, the culture is palpable. you almost feel like you're at a sporting event. You get the sense that everyone is pulling in the same direction. And I left with the understanding that this was an organization that had an amazing capacity for change. So in this picture, I'm showing the clinic manager, and she is making weekly rounds with some of her leaders. And they look at data about everything. They look at the wait time for calls. They look at patient satisfaction numbers. They look at clinical quality numbers. And they look at physician satisfaction numbers. And then they strategize as to how they might improve them. And every wall at Theta Care is lined with data. This is Harvard Vanguard and what's called the Mission Control Room. And every 2 weeks, a new problem is brought to the Mission Control Room for analysis and improvement. And they will look at it through various techniques. They've also adopted Lean. And so here they're doing fishbone diagramming to further delve into a problem. This is South Central Foundation in Alaska. And this is a group of 115 physicians, and they have 26 improvement specialists. So whenever an integrated care team has a process that they want to improve or a problem that they want to address, they can call on an improvement specialist. That person will help to get baseline data, help to see where they are, define current state. And then they help the team map out a future better state and then a way of getting there. And then when they implement their change, the improvement specialist helps them to collect additional data to see if their intervention had been an improvement. So the action steps here that we've identified are at the institutional level. When there's an opportunity, when there's new construction or when there's remodeling, to consider the option of co-location, of having providers and assistants sitting next to each other. To consider line of sight and the efficiencies that come with that. To create space for daily team huddles and time for weekly team meetings. It's very hard to change work while you're doing the work, and it's important to have that time to step away to analyze the work and improve it. And then, as able, to train up employees into improvement specialists. So some of the key lessons that we've learned to decrease burnout and increase joy. First, share the care with the team. The most robust models being 2 or 3 nurses or medical assistants per physician. And that teaming is in stable relationships, the same people day after day working together. With this, moving from a physician-centric model of responsibility, where the physician is responsible for doing every task, to a team-based model where we can share that responsibility. To create forums for clear communication through co-location, through team meetings, and to take a systematic approach to planning with pre-visit planning or workflow mapping. Now, this is the PCC after all, so you might be sitting there wondering, well, how do all these different innovations, how do they relate to the patient-centered medical home? And so I'd like to show you with a couple. I consider these sort of the building blocks or the practical ways that practical strategies for breathing life into the principles of the patient-centered medical home. So in terms of inbox management and collaborative care with collaborative documentation or scribing, both of those things increase the capacity of the practice to manage their patients. They have more capacity. That means they have more appointments. They're able to offer their patients more access. And when you have the ability to offer access, then you have continuity. The patient can see their own physician rather than being directed to another provider. By doing prospective planned care for chronic illnesses and prevention through pre-visit planning, that's a way that we can manage and plan care. Also, co-location helps with the management of that care. And in terms of measure and improve performance, one of the other domains of the patient-centered medical home, having regular team meetings for process improvement is a way that we can do just that. So I'd like to close by going back to those 3 good men that we started with, 3 exemplar family physicians and general internists. I had a chance to shadow Dr. Ben Crocker again 4 years later after my first visit with him. And in the interim, he had helped design and create a new practice also within his organization. So he had moved to a new site, and they had designed this from the ground up to be a practice that engaged patients and that was good for staff and good for the physicians. And what he wrote to me after my second visit was this: the biggest difference is team, culture, and time. Time with patients to better understand who they are, their story. I wouldn't trade that for anything. I'm loving it. And so I think that our collective work going forward, whether we are nurses or physicians or medical assistants or administrators or policymakers or researchers, our collective work is to understand how can we contribute to transformation in primary care. How can we create the environments where physicians can move from saying, gosh, you know, just working at Starbucks would be better, to every day I get up and I'm loving it. And so with that, I'd like to open it up to questions. Thank you. I am not hearing any questions.
Sorry, I'm Ted. You should be. Ted was muted earlier, so I think we're just waiting for him to unmute himself.
Okay. So in the meantime, while we're waiting for Ted?
I think I'm unmuted. Am I okay now?
You sound great.
Okay, thanks. Thank you, Christine and Tom. Outstanding talk. And to the audience out there of 120 folks, I don't know how you felt, but how I felt was unbelievably impressed. I've been a family doctor for 33 years, and there are many things here that I will absolutely incorporate into our patient-centered medical home. And I'm very impressed with what you all have discovered with both shadowing physicians and going to these practices, but also what you're relating to us today. I just want to remind the audience, please, type in your questions in the question box, and then that way we'll be able to ask our presenters your questions. While I wait to have one or two pop up, I just wanted to ask you all what you've discovered around the issue of patient privacy and confidentiality. So, for instance, if there was a sensitive issue emerging between the patient and the physician, let's say around a sexually transmitted disease or impotence or around domestic violence, or if in the exam phase a pelvic exam or rectal might need to be necessary for the patient. What did you both learn in those practices in the sense of how they best handled that? Was the scribe asked to leave the room, or were they still embedded during the process? What thoughts do you have on that?
Well, that's a great question, Ted. And I think I'll answer that from our own personal perspective, because over the last year we have implemented our own collaborative care model, again, where the nurse stays with the patient from the beginning to the end of the appointment. And so one of my major hesitations in initiating that had been, what about that loss of intimacy? And what about that loss of privacy? And I have been reassured by our experience that, first of all, most of the time patients are very, very comfortable with the nurse in the room. And secondly, we initially told every patient that they always had the option of not having the nurse there. I think over the year we've had 1 or 2 patients where we've either ourselves sensed that it wasn't going to be a good fit, or the patient has just gently asked us or indicated to ask someone to leave. Most of the time, if we're doing a sensitive exam, the nurse will be on the other side of the curtain during that part of it. In another practice, one of the things that they did was they allowed the patients, they had like a 3x5 card, and the patient could put that in a certain place on the desk if they would prefer to be in the room alone with the physician. So they made it a very inconspicuous kind of communication that was non-threatening. But by and large, I think that having the nurse in the room has actually enhanced the patient's comfort. They've got this advocate who's there helping them communicate their story.
I'd like to add to that, too, because I was very skeptical about having someone else in the room. I've been in my practice for 25 years, and I have patients I've known over those years, and I didn't want to lose that relationship. But as Chris said, I found it has become enhanced, and it really builds the team as well, because our nurses have developed such close relationships with our patients because they're with them throughout the exam. They understand. They don't just come out of the room and hand them something that they have to do. They've been in the room understanding why these decisions are being made. And in terms of their satisfaction, again, I think it's much greater. And the patients, I thought about this. You know, you don't have one person listening to you. You have two people intently focused on you and trying to take care of you. And I think that that's the sense that they get. Our nurses are very good at this and very personable. So it's actually like having two people attending to you. And the last thing I'd say is I thought about it. I also work in the hospital and do rounds. And I thought, you know, when I'm in the hospital and I'm doing rounds, the nurse is there with me, and we're dealing with very sensitive issues. But it makes good sense because the nurse knows that patient throughout the day, and she has a lot of knowledge to add to it. So my concerns were the same as yours, I think, going into it. But like Chris said, I have just been absolutely stunned at how patients like it and how it's contributed not only to our care for the patients, but the building of our team as we work together to take care of these patients.
Well, thank you both for that. Just one last question, and then we'll get to our questioners as well as we build up a little reservoir of questions. In my practice, I have a lot of patients that have interpretive needs. We have 43 different languages spoken by the patients in my clinic, and I'm just wondering, with interpreters, if you need an interpreter in the room with all of this, the language barrier issue, does it start to put too many people in the room? How have you been able to manage through that?
So that's an interesting question, Ted, and I'd actually be interested in your thoughts on it. In the practices that we visited, we did not observe any visits with an interpreter or focus on that special needs population, and that isn't an issue that we face in our particular community. So I would see a fourth person in the room could be one more person, of course, but from my experience, I would not be hesitant to do this even with an interpreter.
Yeah, I think that's well stated, Chris. I think that all of us are used to practicing in a certain style, and we're starting to recognize that this emerging team approach actually has a tremendous amount of benefit. And I think, patients are probably, quite honestly, more comfortable than perhaps the physicians are with the fact that it can be an expanded number if it's meeting the patient's needs. And so I think that's the moment of insight for me here, too. I'm having some difficulty on my end seeing the questions, and so I'm going to have Lauren just go ahead and read these off to you, because I want the audience's questions to be represented to you both. So, Lauren, if you wouldn't mind.
Or Ted, this is Amy. I can jump in and read them off too. So,
okay, great.
There's a question about the practice facilitation on the quality improvement. Some people were asking, it seems that it might be easier for larger practices or practices that are part of large organizations to have someone come in and do that facilitation. Can you speak to how smaller practices, independent practices, can really start to make these quality improvements to lead towards becoming a patient-centered medical home? Can they do it on their own, or do they need some outside help?
So that, too, is a great question. And I'd like to answer it in two ways. First is change. And we've noticed that some of the change originated from the individual physician and staff and worked its way up, such as Kevin Hopkins or Newport News Family Medicine. And others started more at the top and percolated down. And I think so you can see change starting either from an administrative level or from the individual physician practice level. In terms of small practices, the most effective model that I have seen, and this was really outside of our study, were networks of physicians. So in Maine, there's quite a network of physician small practices that are in a patient-centered medical home initiative. And as part of that, they get together 2 or 3 times a year for meetings. There are practice facilitators who go to those practices to help them. I've seen that also in Georgia, where there's what's called the Patient-Centered Medical Home University, sponsored by the Georgia Academy of Family Practice. And so those were all small practices, but they had these meetings periodically and practice facilitators who could help guide them. My own experience is that much of what we developed in our own practice, we just developed on our own. And we did not have anyone else coming in telling us what to do. And so I think you can, in a small organization or a small pod, create much of the medical home and many of these innovations without external help, but I think external help helps.
I'd like to just add to what Chris said. I think often smaller practices actually have a great advantage. When you're in a large organization, change through the bureaucracy becomes very, very difficult. And as we visit various practices around the country, large organizations often are hobbled by all the various streams of bureaucracy you have to work for just to make some simple change in your practice. As she mentioned, some of the most successful practices that we saw, including Newport News and Kevin Hopkins, they were working on their own basically. I think the key really is team meetings. The communication that a small team has, and both Dr. Hopkins and Dr. Anderson, they meet with their staff weekly or biweekly for at least an hour, and all of this has to be done very, very regularly. And the communication in a small group is often very good and can facilitate quick change, but you have to have those dedicated team meetings to really move ahead.
That's great. So can you speak a little bit more to the investment of the practice, not just in time but financially? You had mentioned in your presentation that some practices actually saw increase in revenue as a result of some of their changes, but there is this initial investment that has to be made. Can you speak a little bit to that and talk about how if there are individuals who are meeting some resistance because that's a perceived barrier, how would you help them address that?
Sure, I'll be happy to. And I think the biggest word that you just said is the perceived barrier. And the interesting thing that we noticed was that some of our practices were under a strict fee-for-service model, a productivity model, and others had a global subsidy from a larger organization. And those that were in the fee-for-service model were the ones that were much more likely to develop techniques of efficiency. So that's where we found the collaborative visit, where the physician's time was leveraged and the physician wasn't delegated a lot of clerical work. And those practices were able to be financially very successful by recognizing that when your highest skilled, highest paid worker is doing work that other people can be doing, that's not a good business model, and they've been able to fix that. In the other practices that were part of an organization where they were getting subsidy, some external support, that's where we found more of the extended team with the on-site pharmacist, the social worker, the nutritionist on-site. So I thought it was interesting how the types of innovations kind of segmented by the financial arrangements in which those organizations were developing.
And this is Ted Epperly again, and I've been able to pull up some of the questions too. So Amy, let's just feel free to back and forth ask as we can. One of our audience members notes that that it seems like the message is that not documenting in the EMR is kind of the key to success. Is that correct? What would you all say to that?
I guess I'd have to clarify the question. Not documenting, assistance in documenting with shared documentation, collaborative care. You have to document, but it's a matter of many of the clerical tasks can be shared with the team. So we're still documenting, but it's done in a shared manner with the team to free up the physician to do physician-level work. I think that's, if I'm interpreting the question right, I'm trying to tell what we're really saying is, no, you don't stop documenting, but you do it through the team, freeing up the doctor to do the high level of relationship building and medical decision making.
But
Okay.
I would like to say, I think that the questioner is actually onto something, because I think we do waste a lot of resources across the country on documentation. And our documents have a little bit of purpose for the clinical communication, but a lot of the purpose is to justify billing or to be defense against liability. And the latter two really consume the bulk of the work. I think if we were only documenting for clinical need, we'd spend a lot more time on the longitudinal portion of the documentation and much less on the individual visit notes.
So maybe you both could walk us through this in terms of the scribe. I'm envisioning the scribe sitting there documenting the note, the history, and the pertinent exam findings, the assessment, and the plan order entry. And then what is the physician's role? Is the physician's role then to review that note, that EMR documentation before the patient leaves, or somehow in the flow of the day? Where does the physician or the provider, PA, nurse practitioner, enter back in to ensure then that that note's accurate, et cetera?
That's a real good question, and it varies from different practices. I'll give you a couple of examples. Dr. Joe Kim, the way he started is that his MAs do his notes, a lot of it into the EMR. At the end of the day, he'll sit and review the notes and add anything he needs to using Dragon. That used to take him quite a bit of time. Now that they're well trained, it takes him maybe 20 minutes, 30 minutes at the end of the day to go over all the notes. Other people do it as they go along. I know in our own practices, we've been doing it. We have really a hybrid note. So a lot of the boilerplate, a lot of the data that needs to go in, our nurses have put in. But I still dictate a note, and my note is brief and it's very clinically oriented, and I always still dictate by plan. So as we've tried to work this model into our own practice, I think a hybrid is really the best, because there's so much documentation, as Chris said, that is simply done for billing purposes, for reliability. We can get that drains the physician, but the true nugget of the note that we want, what's going on, the nugget of the history and the medical thinking, that can be dictated in. That's what we do. So it's a hybrid, but we've relieved the physician of all the excessive documentation that really is not clinically oriented. It's really to jump through hoops, actually.
Okay, thank you. One of our audience members asks, was there any change, either a decrease or increase in staff turnover, either during or after the change process?
So that's a great question as well. And the way I can speak to that is that many of our study sites indicated that their staff was more satisfied than they had been. Staff satisfaction was not the direct focus of our study, so we don't have data on that. I can tell you that in our own organization, our turnover rate is 4%, which is a pretty low turnover rate. And we work really hard to make sure that the work is meaningful for our staff.
Okay.
I think change fatigue is well known in primary care redesign. We've all been reading about it. We all experience it. No matter how good you are, change is painful and change takes a lot of work. So I think some people leave, and like as Chris said, we don't have any data on this, but the experience of the people that I visited, that I shadowed, the people who stay, the people who get turned on by this work are incredibly motivated, and you just sense it. For instance, when you go to Theta Care in Wisconsin, every person in that room, every person in that building is working toward the same goal. You almost feel like you're at a sporting event. There's such a spirit of moving ahead together because they've engaged every one of the persons on the front line. You are important. What you're doing is part of our team. You're not just here serving the doctor. You're here serving the patient. You have a very vital role. And that's the type of thing that I think builds job satisfaction for every member of the staff and really prevents against the high turnover rates that we see so often.
Okay, thank you for that. One of our audience member asks about the physician end of this. Have you run into physicians that are unaccepting of the model, perhaps stuck in that old model and thinking that, again, the only one who can provide the best care to my patients is me as the physician.
So I think that that's the cliche. The physician who doesn't want to delegate any of the work wants to do all the work, the inbox themselves, and not have anyone else touch their inbox. And I'm sure that there are pockets of that, but we actually encountered more were physicians who really wanted to engage their team. And if they were experiencing barriers, they tended to be more regulatory barriers or institutional policy barriers or even cultural barriers among the staff that they wanted to pull in to engage more. Because it's a change for the staff to be able to voice their thoughts about how to make things better and to take a more active role. So I actually observed more of the opposite, that the physicians were really pushing to have a new model and needed to bring administration and sometimes some of the other staff along with them.
You know, Chris, I would just say from, my day job is as a residency director of a family medicine program, and I would agree with that in terms of the upcoming new residents in terms of the models they're looking for. They absolutely are all over this kind of concept of teamwork and how physicians can focus on physician-related work. So I think that who's coming through the pipeline, too, will be all over this. Another question from one of our audience members was asking about nurse practitioners. Are they in panel with their own panel, or are they part of the team panel with the physician? How does that work that you've observed?
Sure. Another great question. And although our study was really focused on physicians and practices with physicians, we observed nurse practitioners and PAs in those same practices and in other work that Tom and I have done. And in the practices that we've been privileged to see, the NPs and PAs had their own panel, and they functioned very much as independent providers of practice. And incidentally, experienced the same problems. Leave practice. I know of a physician's assistant who left one of the local universities because she could not keep up with 2 hours of work every night. And I think we're seeing that NPs and PAs are preferentially choosing orthopedics over family medicine, and they suffer the same stresses and benefit from the same kind of teamwork.
Okay, wonderful. Questioner was wondering about families. Are families allowed into the room, or is it, again, because of kind of an earlier question, a bit overcrowded? What did you observe around families being present in the exam room?
My observations were the families were there just as much as in other practices. There's, for instance, at Joe Kim's practice, they've actually made bigger rooms to make sure they accommodate that, but I have not seen any case in which they denied access to the families. Every practice I want to have family members in the room with the patient just as much. It might be a space issue if you've only got very tiny exam rooms, and that's a remodeling issue, I guess, but there was no sense of excluding families.
Okay, wonderful. Another questioner was wondering about family advisory councils or patient advisory groups. Did you see in these highly functional practices a movement towards family advisory councils or patient advisory groups?
Yeah, we sure did. For example, the Massachusetts General Hospital has patients or families on many of their committees. Data Care has patients and families represented on their committees. And at Data Care, they actually, as part of your employment interview, you're also interviewing a patient. And so they reinforced right from the beginning that your job as part of an employee there is to take care of the patient and be part of the patient and understand the patient's perspective.
Okay. Another questioner was wondering, is there a single technology initiative or workflow improvement that brought about benefits? What would you say to that from your synthesis of all this?
A single, of course, we found many, many different initiatives. I think in terms of low-hanging fruit, I would put forth two things. One is plan your appointments, using your technology to hold future orders, schedule the patient for their follow-up in 3 months with lab 2 days before, use technology to send them a reminder text, a reminder phone call, a reminder letter, so that they can have their lab ahead of time. That's such low-hanging fruit because it frees up time for the staff to then do some of the more higher functioning medical home activities of health coaching and care coordination. And the other one, and it's not so technology-based, it's just organizational-based, is to synchronize all the prescriptions for chronic illnesses at the annual exam. And that, too, offloads the practice of a lot of unnecessary work and frees up personnel time to do higher value work.
Okay, thank you. Amy, back to you. A question that you had from your observation of the questions.
Sure, great. So going back to one of the things that was asked about a little bit before in terms of a space issue, if there are practices that really have limitations related to space, are there one or two things that you think that they could do if they could only pick one or two things to do and make some environmental changes? What would you recommend?
Limited space environmental changes. Well, I think the answer is going to be really different in each area. One of the things that they did at Theta Care was they had a light that went on in the central area whenever the blood was drawn and someone needed to take it to the lab quickly. And that engaged everyone in making sure that lab results got back quickly. So that was an innovation that didn't take space. At the University of Utah, every person had a Vocera device so that they could talk to each other through this headset without having to go chase down the halls looking for each other. And I think the other piece in terms of space probably would be to find ways to do co-location. When the physician and the staff sit next to each other, that actually frees up a physician office, and it decreases the amount of walking back and forth that people are doing to find each other. So I might look to that as another option.
Those are great suggestions. Flipping back to, instead of the small practice, if you're working with an organization that has multiple sites, lots of primary care practices as part of their network, and they're all doing quality improvement, do they all take a different approach? Are they all doing it at different paces? Or does the large system pick one change and try to get it implemented across all those practice sites? And then what's the speed by which they do that? Do they try to do it all at once, pick a handful of practices to do it in? What are your recommendations along those lines?
I think that's quite variable. As Chris said, some change comes from the bottom and some comes from the top. So at some places, one particular practice will develop a number of innovations, and then the larger organizations will take those ideas and spread them across the larger organization. In other cases, an administrator might hear about a good idea and then try to spread it through the entire, through the entire group that way. Chris, we can speak to some specific examples, maybe Theta Care.
Well, I was thinking about Mayo Clinics, and there were different innovations being piloted at different satellite sites, and it's one of the great advantages of being a large organization that has multiple sites. And so the new model of nursing was happening at the Mayo Red Cedar. They also had a scribing pilot happening at another satellite. And then we were fortunate to be speakers at one of their conferences where they brought all the different sites together and they shared their innovations. At Cleveland Clinic, they are piloting 3 different models of primary care, one of which is the model that Tom talked about from Kevin Hopkins, but there are 2 others. And then they're going to compare those 3 and decide what are the strengths, what are the weaknesses, what is it that we want to then implement across the whole organization. So my answer would be I would recommend starting with small tests of change in small pilots with enthusiastic people, work out the bugs, try several different models, and then choose the best of all.
Thank you, Chris. A couple other questions from folks. A couple people were interested in knowing, is there a difference in the model between an RN or LPN and an MA? Are they interchangeable in this model? What would you say to that?
So I think in answer actually to that question that you asked earlier about physicians being wary of sharing the care with other members of the team, one of the important factors, I think, is that the people that you share the care with have to be really skilled. And so there's, I think, more willingness to share the care the more skilled that those people are. And a lot of that skill comes from the investment we make in their training. We're very fortunate in our own practice to have RNs as our practice partners. And I think the training of a 2-year associate's degree RN is just really well suited to this medical home work. But I recognize that not everyone is that fortunate, and we have seen some very highly functional MAs. But I think the issue is investing in their training. So North Shore Physicians Group has developed an entire teaching them about self-management support, about motivational interviewing, about panel management. So I think training and skill level is important, and that there's a spectrum from MA to RN. I like the RN model. I think we can take it even further than we have and have the RNs do even more of the chronic illness management. I think it can work with all settings, but I don't think that we should expect the same work output from each one of those health professionals.
Yes, it gets back to the concept, Chris, of kind of working at the top of your license that we talk about. And I love the idea of on-site training to, kind of dial in the assistant, either the MA, LPN, RN, to what you need in the practice. I have a question here, I think extremely thoughtful, from one of the audience members. We've had great questions, by the way. But this person is asking, if the physicians or the practice is already burned out, which many, many are, how do they find the time, energy, motivation to even embark on these improvement efforts?
I think that's a great question. I think that's what we're facing. That's kind of the reality of where the world is at, to tell you the truth. And as I said, people we talk to, many of them have been burned out or on the edge of burnout. And somehow they found the way to get there. I think for myself, I think I've been on the edge of burnout myself years before entering into more excitement about practice redesign. The big thing, I think, is teams and having this shared mission. The weekly team meetings for me really help me to keep focused on what we're trying to do. And we work out problems, we make things go more smoothly. And I think the support of the team, and that if you can get team meetings going, and that can help. I'm not saying it's a cure, but I think the communication within the team and moving forward toward a goal of better patient care and better satisfaction, more job satisfaction, if you kind of work together on that, I think you can get support there. I think, people like you folks who put on great conferences where in IHI, that's where we get a lot of our inspiration. If we can get, we've taken our nurses to IHI, and to get people engaged again and see, hey, there are places out there where it's fun and people are doing great things, and maybe even take your team to another clinic and have them shadow a good, well-operating clinic, and talk, have the nurses talk to the nurses and the nurse managers talk to the nurses and managers. And that might help too, just to say, hey, there is something else out there besides what we're doing. I think those are two possible contributions.
Okay, thanks, Tom. I have one other question here. I don't see any others in the queue that I see here. And Amy, if you do, please feel free to ask one. But let me ask this question. Obviously, we're going through a major transformation of our healthcare system now for all the right reasons. We're trying to get away from fee-for-service, trying to get more to a blended payment where we could make use of non-face-to-face service fees, either through a per member per month or capitation, or through quality payments, or even shared savings. Right now, the model, as you've described, still is kind of on a face-to-face fee-for-service basis. What have you seen or observed in terms of payment model reform that could either augment or help these practices? And what sorts of payment approaches did you see out there and that you're aware of?
Sure. And I think the questioner has hit on a really important topic, and that is we can't deliver care that we really aspire to in the current environment. We can improve, but we will never be able to get where we need to go without some sort of recognition that our value is in cost. And so a care coordination fee or some shared savings so that we can invest in the local team to have home visits, to have phone visits, to do all that other kind of between visit care. I think that's essential. And I am encouraged that we'll move forward in that way. I don't think we need to wait for the end of fee-for-service. In fact, I'm like you, Ted, I think a hybrid is what we need, a blended payment system. We can still benefit under the fee-for-service model by being more efficient, which I think makes us happier and makes our care better. But if we really want to get this extended care where we can afford a pharmacist, where we can have an on-site social worker, we can have teams going to visit patients at their homes, we need more of a care coordination fee.
Yeah. Well said, and I would concur with that, and that's why I think that healthcare reform with new models will be exactly what we're trying to get at, which is to make sure that the value add is being appropriately recognized, paid for. That's what will start to not only return the joy to practice, as you both have so well pointed out, but start to really get the medical student interest turned back into the right direction for the right reasons. Amy, before we wrap up, I know that many of the audience, first to you both, outstanding. We've gotten such great comments back from the audience on this. Many were wondering about the slides that they could get, they could utilize, the recording potentially to utilize, road trips from you two to potentially present practices, etc. Amy, what would be your response to our audience in regards to the ease of how all of those could be accomplished?
Sure. So we'll have this webinar. It's being recorded now. We'll have it available up on our website within 24 hours. So you can just go to the pcpcc.net website, click on Events, Webinar, and there's several other places that you can access our resources and webinars. So you'll be able to find it there. And if anyone has any specific requests for our speakers, like you want to have them come to your town or your practice if they have the availability, you can send those to me and I can forward those on. You can send them to agibson, A-G-I-B-S-O-N, at pcpcc.net. I'd be more than happy to forward those on to the Zinskis. I think we have time for one more question. You talked a lot about the different capacity and restructuring the staffing within the walls of the practice. Did you observe any practices who had some really exciting, innovative partnerships with others in the community? So maybe with the local Y, or perhaps with a home care agency, or even services that might be provided like dietitian-type services in churches or other community centers. Did you see anyone working in partnership with community providers?
So that, too, is a wonderful question, and I think that's almost the next frontier. And the place where I feel that that's probably the strongest is in Camden, New Jersey. That wasn't part of our study, but Jeffrey Brenner has done terrific work with his hotspotters, and I believe there's a lot of connection with community resources going on there. My hope is that as part of the medical home and medical neighborhood, we all have a component of our work directed out-facing to the community. How can we make sure that the community supports healthy behavior and supports best care of our patients with chronic illness? Amy, I also wanted to ask if you would be willing to put on the website and let people know that they can read more about this both at the Annals of Family Medicine website where the Joy in Practice study is published, but also on the American Board of Internal Medicine Foundation website where a much longer white paper is published describing our findings, as well as individual site visit summaries for each of our 23 sites, as well as a research agenda, some additional resources that emanated from this work. So those are all.
Yeah, definitely. That's a great suggestion. We have many of those already linked on the website, but we'll put a special link on those next to the webinar so everyone who's on and has participated today can have a one-stop shopping and find all of those really easily.
Let me just go ahead and take this opportunity to wrap up for us. We're right at the bottom of the hour. And to you, Chris, and to you, Tom, thank you. Thank you for your great work, your great presentation. I think this is foundational in regards to helping all primary care physicians get to a better place and how we effectively and efficiently deliver care to our patients. I, too, have been close to burnout on several occasions. I know there's got to be a better model. I was energized and inspired by your talk. So I appreciate it greatly. And on behalf of the PCPCC and our Center on Care Delivery and Integration, and behalf of this audience, I thank you very much. And to all the folks that are out there that participated this morning and afternoon, depending on your time zone, thank you and enjoy your summers. And with that, we'll sign off. Thank you, everyone.
Thanks so much.
Thank you.
Bye-bye.
Bye-bye.